Hi, everybody. On behalf of the Northwest Mental Health Technology Center, I'd like to welcome everyone to today's webinar. I'm Dr. Sarah Kapelovich, Assistant Professor in the Department of Psychiatry and Behavioral Sciences at the University of Washington and core faculty on the Northwest Mental Health Technology Transfer Center. This webinar is sponsored by the Northwest MHTTC, and on behalf of the entire team, we're excited to welcome Dr. Margie Balfour, who will be sharing her expertise on the topic of creating and sustaining high-quality crisis services. Before I introduce Dr. Balfour, I'd like to review just a few housekeeping items for those who are joining us live. If you have any technical issues, please submit your questions in the chat box and one of our staff can work with you. We also welcome your questions to Dr. Balfour and ask that you please submit these in the Q&A box. We'll compile the questions and review them at the end of Dr. Balfour's presentation. The MHTTC network is funded by the Substance Abuse and Mental Health Services Administration and consists of a national coordinating office, 10 regional centers, a tribal affairs center, and a Hispanic and Latino center. Together, our collaborative network supports resource development and dissemination, training and technical assistance, and workforce development to the mental health field throughout the United States. The Northwest MHTTC is based at the University of Washington in the Department of Psychiatry and Behavioral Sciences. We provide training and technical assistance in evidence-based practices to behavioral health and primary care providers, as well as school and social service staff whose work has the potential to improve behavioral health outcomes for individuals with or who are at high risk of developing serious mental illness in Region 10, which covers Alaska, Idaho, Oregon, and Washington. And our goals at the Northwest MHTTC are to heighten awareness, knowledge, and skills of the workforce, addressing the needs of individuals with mental illness, to accelerate the adoption and implementation of mental health-related evidence-based practices across Region 10, and to foster alliances among culturally diverse mental health providers, policymakers, family members, and clients. Before we get started, I'd like to take just a moment to ask who we have with here today. And so I'm going to just push out a poll asking just that. You'll see that come up on your screen in just a moment. When you get that poll, it'll ask you what best describes your role. Fantastic. So we have some legislative staff. We have about 8% are peer support specialists. About a third of our attendees are clinicians. We have 10% healthcare administrators, social workers, and individuals with the mental health administration at the state. Fantastic. Okay, you'll see one more poll being pushed out now, and that is to ask how familiar each of you are with crisis systems and services on a Likert scale from 1 to 5, 1 being not at all familiar and 5 being extremely familiar. And we've got a great distribution here, 4% indicated not at all familiar, with about a third of our sample being somewhat familiar, a third of our sample being moderately familiar, and the upper 16% is extremely familiar. So great distribution. I think we have a great group here together. And so without further ado, I'm going to go ahead and introduce our speaker today. And I could not be more excited to introduce Dr. Margie Balfour, a psychiatrist and national leader in quality improvement and behavioral health crisis services. Dr. Balfour is the Chief of Quality and Clinical Innovation at Connections Health Solutions, which provides access to mental health and substance use care throughout the state of Arizona. She's also an associate professor of psychiatry at the University of Arizona. Dr. Balfour was named Doctor of the Year in 2017 by the National Council for Behavioral Health for her work at the Crisis Response Center in Tucson. She was also awarded the Tucson Police Department's Medal of Honor for her efforts to help law enforcement better serve individuals with mental illness. She serves on the board of directors of the American Association of Community Psychiatrists, the American Association for Emergency Psychiatry, and the National Alliance of Mental Illness in Southern Arizona. Dr. Balfour earned her MD and PhD in neuroscience from the University of Cincinnati and completed her residency and fellowship in public psychiatry at the University of Texas. We're very excited to have Dr. Balfour share more about her work today. Thank you, Dr. Balfour.
So anyway, thanks for having me. And so I'm here to talk about crisis services and thank you for that lovely introduction. And what better time to talk about crisis services than in the middle of a crisis? But first, I kind of want to start with why, why so much talk about crisis services and why we need them. And really, we have this weird system set up in our country where if you call 911 for an emergency and you have a medical issue, you get a nice ambulance and a well-trained EMS staff. But if you say that you're suicidal, you get law enforcement. And as a result, a lot of our folks end up in jail because officers, even if they're getting training, so many people are doing CIT training in their communities, and officers are recognizing that people need mental health care rather than going to jail. But if they take them to an ER, they have to wait for a long time, and they're busy and they have crimes to fight, and so they end up taking the person to jail instead. And so the jail data bears that out. There's over 2 million jail bookings of people with serious mental illness every year. A survey from NAMI revealed that about half of people with SMI said they've been arrested at least once. I tell my colleagues in private practice, if you think that justice issues aren't relevant to you, it's just you haven't asked your patients, because so many have a justice contact. If you look inside the jails, the red numbers are the prevalence of mental illness inside the jail versus the general population, and you can see it's much higher. And kids as well. 70% of youth in the juvenile justice system have some kind of mental disorder, and at huge cost to the system as well. And if they do make it to an ER, it's not much better. So the little skeleton is kind of showing how long people have to wait. 84% of ERs report psychiatric patients, which is patients waiting in ERs to be transferred to a psych bed. And this results in increased risk to the ER. Patients are there for long periods of time not getting treatment, so they end up decompensating and becoming assaultive. There's injuries to themselves, injuries to staff, increased costs, tons of resources being spent on sitters, and lost revenue from not being able to use those beds for other things, and just a really poor patient experience. It's not a very therapeutic environment for a person with the psych issues to be in. And especially now during the whole coronavirus crisis, I think it's even more important for crisis centers to be able to relieve that burden on the emergency rooms and take care of the psychiatric patients in a way so that they don't add to the ER overcrowding that's going to be such a problem. And at the end, if you want to ask questions about some of the things we're doing around that, I'm happy to talk about that. So what do you need for a crisis system, though? So this is a slide that I stole from an old slide of SAMHSA's from a while back that talks about all the different services. And we talk about all these different programs and special services and, doing this service and that program. But really, it requires that all of these different services work together. It's not just the collection of services themselves, but it's how they're organized and coordinated to all work together to achieve common goals. And then you end up where, it's more than the sum of the parts. And so the way in Arizona, what we've learned is that there's really three key ingredients for a system. One is that there's accountability. So who's responsible for this system? And what's a lot of times that's related to the governance and the financing of it around, but some accountable point of accountability to hold the system values, to define what the outcomes are, and then to be able to hold the different components of the system accountable. Then collaboration. Crisis involves tons of different collaborating partners, the people that are operating all the different clinical programs, as well as stakeholders outside the healthcare system, so law enforcement, counties, schools, like all kinds of different partners. So it's really important to have a a culture where people are collaborating and working together, but also a structure that that facilitates that kind of collaboration. And then data. I'm a data nerd, so I love data. And if we're saying that we have common outcomes and common goals, how do we know that we're achieving them? If we are holding people accountable to certain goals, how do we know, what if people are meeting those? And if we're going to make decisions, let's make decisions based on data. So having a data structure is very important for a crisis system. And so I'm going to talk about Arizona as kind of an example of how some of these things can be operationalized. We're fortunate in that our system is structured to kind of bake in some of those things already just into the structure. So, Arizona is an interesting state. We were the last state to ever have Medicaid, not just Medicaid expansion, but like Medicaid at all. And when I first moved out here, I was so excited to see that I came from Texas, which funds Medicaid the way you would expect Texas to fund Medicaid. And so I came out to Arizona and we have all this Medicaid expansion. The name of the department is called Access. I'm like, that's great. It's all about access to care. It stands for Arizona Healthcare Cost Containment System, which is kind of not what I thought it stood for. But it's really interesting in that it's been managed care from the beginning. So we were the last state to have Medicaid, but the first state to have a statewide managed care waiver. And so the benefit of that is that somebody has always been thinking of our system as a system. We've never had fee for service Medicaid. It's always been through these contracted waivers where, someone has to actually organize it. So the way that it's currently structured is we have Access, which is our Medicaid department. And then the state is divided into three regions: the North, the South, and the Central. And then they contract out uh, a contract for the region to be the regional behavioral health authority for that region. So I'm going to be talking mostly about the South, which is the dark blue, and specifically Tucson, where the Wildcat is. And our regional behavioral health authority is Arizona Complete Health. They're part of the Centene Corporation, and they get a bunch of different funds braided together. They get the SAMHSA block grant funds, they get the Medicaid funds, their state general fund dollars, there's funds that the county puts in, and they are a single point of accountability to administer those funds, to pay for the services, and to contract with all the different crisis providers. And so it kind of bakes in a governance structure that supports the organization and accountability of the system. Sometimes we refer to Arizona Complete Health as our benevolent overlords, because what this means is our regional behavioral health authority is kind of like the conductor. So we've got all these different services, all these different providers, but there is a single point of planning, accountability. And then really this is a good example of where clinical goals and financial goals are aligned, because what I want as a clinician is I want my patients to not be in jail and not be in the emergency room and not be in the hospital if they don't need to be there, to be out in the community doing well. And if you're actually paying for all of that stuff, then you want that as well, because people being well in the community is much less expensive than people being in emergency rooms and hospitals. This is kind of an example of how this structure can lead to strategic service design. So a few years back, the state had a big initiative to reduce the justice population of people with SMI in the justice system. Because why would a Medicaid managed care company care about people being in jail? I mean, besides the fact that I'm sure there's nice people, but if you think about it from a financial point of view, once people are in jail, they're kind of off the spreadsheet of the Medicaid department, because their Medicaid gets turned off when they're in jail. But the further up you look, I mean, all that money ultimately comes from the same place, which is us, the taxpayers. So our governor was doing kind of a smart government initiative where he had the different department heads meet with each other and share their budgets and to try to come up with some shared strategic goals. And that's where this reduced the justice costs for people with SMI came from. So then that filtered down to Access, our Medicaid department. So that became one of their goals. So when they did their RFPs and their contracts with the Medicaid managed care companies and the regional behavioral health authorities, it included requirements around reducing the justice involvement. So there were questions in the RFP that said, answer how you will do this. And there's contractual obligations in there now. So then when they contract down with the regional behavioral health authorities, which are at risk, and so they need to do what's in their contract, or else they'll get, penalized, or they can get rewarded. They use that mechanism to um, then create services and processes with their subcontracted providers like us that are targeted at reducing justice involvement. So one example is, if we're trying to keep people out of jail, law enforcement officers that have all the people that might end up in jail that we would rather have in services. So there's this concept of treating law enforcement as a preferred customer. And so that filters down to the subcontracted providers. So the crisis line has things in place to make it easier for law enforcement to access them. The mobile crisis teams have performance requirements on how fast they respond to a crisis out in the community. And if law enforcement is asking for them to respond, they have to respond faster. And then I'll talk in more detail about our crisis centers and how they're really set up to make it very easier to access us than to access jail when they have people in need of services. So this is kind of a schematic um, of how ideally these services can be aligned to meet these common goals. So this kind of shows, you got a person in crisis, and we want to have least restrictive options, which also tend to be the least costly, at every point to be able to get people's needs met in the least restrictive way possible. So, for example, the crisis line for Southern Arizona, which is run by NurseWise, it gets about 10,000 calls a month. And if they're able to do that crisis counseling on the phone, they resolve about 80% of those crises. They're able to do crisis counseling. They're able to make appointments with people. There's contractual obligations for the clinics to put appointments in this database that the mobile team, or that the crisis line has, for example. But then if they can't resolve that crisis, they can escalate it up and dispatch a mobile crisis team. So there's 16 mobile crisis teams operating at various times of the day in Pima County, and they are able to dispatch them centrally from the crisis line. So they have little GPS located phones, and they know where they all are. And so if the mobile crisis team then responds and does a face-to-face encounter, they resolve about 70% of those. And then if they can't resolve that, they can take them to one of the various 24/7 crisis facilities. I'll be talking about ours, which is in Tucson, which is the major metropolitan area for Southern Arizona, but there's other smaller ones in the rural areas as well. And then if we're able to, in our crisis centers, we keep people overnight and really work on trying to resolve their crises. And 60 to 70% of those folks can go home to the community the next day. And then there's wraparound services to keep people stable for up to 45 days out. And so the result of this is decreased ER, jail, and inpatient use. And at every point, because we want to divert people out of the justice system, there's easy access for law enforcement. So the crisis line, there are now crisis line staff that are co-located in the 911 call center that can intercept calls and never have a police response to those. As I was saying before, the mobile crisis teams respond faster to law enforcement. We also have some co-responder teams. And then the crisis facilities are set up for easy drop-off. So that's what it looks like in the nice, pretty schematic. In reality, there's tons and tons of different programs. This just kind of shows a lot of our partners. And if you ask a law enforcement officer, well, you're supposed to divert people to treatment, and then they say, well, divert to what? And the services around here they really hammer home the idea of there's no wrong door. So the officers can access any of these services, and then we on the back end figure out where the person best needs to be and never turn that officer away. I'm going to be talking about our crisis response center, which is kind of the center piece of a lot of this for Tucson area. And the Crisis Response Center, or CRC, was built with Pima County bond funds in 2011. It was really driven by the county wanting to decrease the psychiatric population in the jails, because of course they run the jail, but also the ER and hospitals, because they run those as well. And we serve about 12,000 adults, 2,400 kids per year. And it really is meant to be the law enforcement receiving center with no wrong door. I'll talk about in a minute about how we don't exclude anybody they bring us. They can be as agitated and high acuity as anything. But there's also services for anybody who wants to walk in for care. So our services for both the adults and kids have a 24/7 urgent care where people can walk in, say, I'm new to town, I need to be hooked up with services, or I'm out of my meds and I missed my appointment, and we can get those resolved in kind of an urgent care clinic setting. The heart of the operation is our 23-hour observation unit, which keeps people overnight and tries to resolve that crisis rather than sending them to the hospital. And then if we need to, for the adults, we have a short-term subacute inpatient unit. And then we also can send people out to all the different hospitals around the community. There's space for co-located community programs. We've had peer-run post-crisis wraparound programs, pet therapy, other organizations coming in from the outside to provide services for our people. And it's part of this really neat campus that's adjacent to which basically the county hospital. So it's Banner University Medical Center. There's an ED with actually it's a mistake. It's a level 3 trauma center. There's the crisis call center is in our building. It's run by a different agency, but they're in our building. The bond also built a 66-bed inpatient hospital where most of the civil commitments go. And there's a breezeway that connects us to that and the ED. And then there's a mental health court right there too. So all the patients don't have to be taken all over the place to go to court. And they also can do some low-level criminal warrant resolution stuff in there too. And this is kind of our model. Actually, our corporate mission is we address any behavioral health need at any time. And that's not on there as like an ad, because it's really on there because that is the mentality you have to make this work. So the box on the right is the criteria from the old original CIT writings that back from like the early 2000s. If you actually go back to Memphis and look at the CIT model, a lot of people talk about it as if it's just the training of the law enforcement, but it's really a more systemic approach to that, because if you train law enforcement to bring people to treatment, they have to have somewhere to take them to. And so the old CIT criteria actually lay out what should these mental health receiving facilities have. And I highlighted the two in the middle because we go around the country, we consult and stuff. And this is the two things that we see that people have the most trouble with, is having no clinical barriers to care and getting law enforcement in and out as quick as possible. So our model is that we take everybody. There's no wrong door. There's no such thing. People will call us up, well, what is their blood alcohol is too high? We said, well, we don't have any exclusion for that. If they can sit up and eat a sandwich, they can come here. There's no such thing as too agitated. We actually like those people. We think we do better with them than if they went to the ED, where they don't have the setup to take care of people with behavioral health needs very well. They could be voluntary or involuntary. They can have. We try to say yes. That's kind of our motto, is try to figure out how to say yes rather than look for reasons to say no. They say sometimes it's easier to get into heaven than an inpatient psych unit, and we try to not do that. We try to take anyone that we can. And there are studies that show that this model, if it works right, it helps with pre-arrest diversion, it reduces ER boarding, and it reduces people going to the hospital if they don't need to be. So this is our really key feature to making this work, is having easy access for law enforcement, so that they actually prefer to come to us rather than the emergency room or to jail. And so they have their own dedicated entrance. There's a gated sally port where they can buzz a buzzer, opens the gate, closes behind them, so it's a secure area. Law enforcement comes in, they get in and out. We found what law enforcement really wants is they want the quickness, but the other thing they want is no one to be hassling them to take their guns off. Because I don't know if you ever asked law enforcement to take their gun off, but they don't like it. So we got them everything they need back in one area, so they don't have to walk around the building and then have staff hassling about having their guns on in the clinical areas. So they have an office where they can do their paperwork. We've got water and refreshments for them. They have their own bathroom. And so it takes we were told it takes about 20 to 30 minutes to book somebody into the Pima County Jail, which actually it takes longer, but we set our standard for 10 minutes or less, which we pretty much hit every month. So once the folks are in our facilities, like I said, the heart of it is the 23-hour observation unit, where we are trying to provide a safe and secure and as therapeutic as possible environment. So if these are in the criteria for people to be in our OBS unit, is pretty much the same as inpatient medical necessity criteria. So, danger to self, danger to others, acutely psychotic, intoxicated, agitated, and withdrawal. And if you have people who are potentially a danger to themselves, the way you keep them safe is observing them continuously, so that we can make sure that they're staying safe. And so that's why it's an open area. It doesn't have individual rooms like an ER does. Um, because staff can always visualize the people. The other reason it's open is because if you think about what happens in an ER, where you put people in the room by themselves, they put a sitter with them who's the policy not supposed to talk to them about why they're there, and they stare at the wall for 12 hours, and that is not very therapeutic. Um, there's a reason why before we even had medications, a lot of the old state hospitals had the moral therapy, milieu therapy, where just being in an area where you can interact with each other has a therapeutic value. That's why psych hospitals today all have that open day room. So that's another reason why we have it as an open area. So people are off interacting with people. We have peer supports who are doing one-on-one work with people and also doing groups, and just really trying to make it a therapeutic environment. Um, a big hallmark of what we do there is interdisciplinary teamwork. So we have 24/7 coverage of either a physician or a nurse practitioner or a PA, and we try to get them seen as quick as possible so we can start treatment. Our door-to-doc time, the median is right around 2 hours. We have peers who are doing lived experience. They do groups with people. They do one-on-one interactions with people. We have nurses because we have a lot of people who need or have some kind of protocol for detox. So they're making sure that they're getting their withdrawal managed. We can start Suboxone if we need to. We also have our behavioral health techs who are keeping the whole environment safe and are very highly trained. We don't use security. We we exclusively use our behavioral health technicians to help keep people de-escalated and keep people safe. And then we have our crisis workers who are really working on discharge planning. So they are trying to immediately they're on the phone with the person's family, with their friends, with their clinic, whoever their supports are, trying to figure out what's going on with this person and what do we need to do to get them back stable in the community, because we go at it with this assumption that we're going to resolve the crisis, and then only after that 23 hours, if they're still in crisis and what we've tried hasn't worked yet, then we'll work on inpatient stabilization. So the police are a huge part of our partnership too. So the Tucson Police Department, they are a huge partner of ours. They have like one of the most sophisticated approaches towards mental health in the nation. They're a learning site with the Bureau of Justice Assistance or the DOJ, and they are all in terms of training. So all of their officers receive the basic mental health first aid. Um, they feel very strongly that CIT should be voluntary, that it works best when it's people who want to be doing it. They've done all these things to incentivize, such that now 80% of their first responders and 911 call takers have voluntarily received CIT. And then they have some specialized units that get even more advanced training. So there's the SWAT and hostage negotiators get that advanced CIT. And then there are specialized mental health teams, which is kind of a unique innovation of the Tucson Police. The MISS teams stands for Mental Health Support Teams. These were created after so unfortunately, we're not a stranger to tragedy. We had the Jared Loughner shooting that involved Congressman Gabrielle Giffords. And after that event, the community really looked to see, well, how did we miss someone who was clearly falling through the cracks, who needed mental health help? And as part of that, they created in addition to all of the 80 people who have CIT, there is this specialized team that just focuses on mental health, and that's all they do. I think it's now about officers and 3 sergeants and 2 detectives, I think is the size now. But they basically, we have a lot of people on assisted outpatient treatment. They do, or people that, whether it's orders to pick them up to be evaluated for civil commitment, they do all of those pickups. They do it in plain clothes with the unmarked car, and they start to develop relationships with people. They recognize patterns. They really serve as the experts for the patrol officers, even the CIT ones. And then the really innovative thing is then they have their detectives, which the way it was kind of explained to me is this is a huge shift for police departments to investigate things that are not crimes. Because if you get robbed, you call the police, you get a robbery detective. If there's a murder, there's a homicide detective. But if you're calling to say, hey, my neighbor looks like they're not doing quite right, there's something up, that's not a crime. And so those are typically never investigated. And this team focuses exclusively on that. And they're looking for people at risk for falling through the cracks. And the focus is to get them connected to treatment and keep them out of the justice system. So they kind of, they're the weird stuff detectives. It's kind of what they do. And so the data from this. So this is the number of mental health transports from Tucson Police Department going several years back. And you can see it's just been going up and up and up and up. And the question is always like, well, is this good or is this bad? And we think it's good because it means that uh, there's more people who are being taken to treatment instead of ending up in jails or ERs or wherever else they might end up. The graph on the right is our police drop-offs. So that's the number of police drop-offs we get per month. The circles are the turnaround time, the median turnaround time. So we're keeping it around 10 minutes. And what's interesting with this is everywhere else that I've been, most of the time when the police bring you somebody, they're under whatever your state's involuntary hold is. Well, here the light part of the bars are voluntary drop-offs, and so the majority, about 2/3 of who they're bringing us, are voluntary, which one of our docs calls the Uber police. But it's really a good thing because it shows that they're actually going out and they're engaging with people and saying, "Hey, would you like to come to treatment?" And so these are kind of the low-level people that might get picked up for stuff like yeah, so these are the people who get picked up for what the police call nuisance calls: vagrancy, drinking in public, civil disturbance. I was in one jurisdiction where they use aggressive jaywalking is the thing they pick people up on. And so these are all these low level things that land our people in jail because well intentioned officers are just trying to get them off the street. And so over the years, we've seen these continually decrease. And then another thing is that with more availability of crisis services and more integration of mental health and justice training, is that there's a whole culture that changes in how people respond to mental health crisis. So this is one thing that is surprising to me when I first moved here, that if apparently this is the case in most cities, where if there's an order to go pick somebody up, like an emergency hold or whatever your state has, to go bring somebody to the hospital because they're suicidal, and the police go to the person's house and knock on the door and say, we got to bring you to the hospital, and they say, go away, that's a barricaded suicidal person, which often ends up in an automatic call to the SWAT team, which my law enforcement buddy says, well, if they're not going to come out for just my two plainclothes guys, are not coming out for 30 guys in a tank. So why do we do that? So they've completely stopped doing that, and for the most part. And each one of these costs $15,000 to deploy the SWAT team. So you can make a financial argument to the police department as well, in how valuable it is to have a mental health focus the way that Tucson Police does. And this shows some of our data around discharging. So again, we're trying to get people to the community in the least restrictive way. So we discharge 65%, about end up coming in, meeting criteria for an inpatient admission. Like you could call an insurance company from an ER and they would give you, approval to admit most of the people that go into our observation unit, but 65% go to the community the next day. Even if they don't, even if they need inpatient care, we really work on trying to do things in the least restrictive way. So we also track converting people to voluntary status so that they're engaging in a less coercive way of treatment. And then these are just some more law enforcement mental health collaborations, more recent ones that have been going on in our community. We've got co-responder teams. They're really focusing on following up with those detectives on some of their investigations. We've got a deflection program now where there's a grant through SAMHSA that there's another agency in town called Kodak, and they have peer people who co-respond with law enforcement for people who overdosed or have substance use issues, and they have the option to not arrest people for small amounts in paraphernalia. And then there's a new homeless outreach team that's really targeted in our parks. which is where a lot of our folks are, that's trying to identify and engage people needing services. And then I'm a data person, so I'm going to talk briefly about some of the data stuff that we've done. So there aren't any measures for crisis facility services. I think part of that is because most crisis services are funded at the state level via Medicaid. Every state does something differently. So there's not really been like a federal oversight of crisis outcomes. So we created our own measure set just because we had multiple facilities in Arizona and needed to be able to compare performance across facilities. And we used a tool called a critical to quality tree, which basically it's a quality improvement tool where you look at what value are you trying to provide. And then, so we broke those out into things that are very similar to the Institute of Medicine's goals for improving healthcare, but kind of tweaked for behavioral health. So we look at timeliness and safety and accessibility, but also least restrictive care and partnership with the community, things that are very geared towards crisis services. And we've published this, so there's a link to it in the slide. And that our measures are always a work in progress. These are kind of the key ones, and there's a lot on that previous slide, but these are kind of the key ones that we really look to as kind of our core measures. So we look at our length of stay, like how long it takes people to go through the urgent care clinic, so we can get people's needs met, so they prefer to come to us rather than go to the emergency room or let their symptoms get worse. We look at the door to doctor time for our OBS unit to make sure that treatment starts early. We try to keep that around 2 hours. Our community disposition rate, which we talked about, is the discharging people to the community. We do have the ability to do seclusion and restraint. We don't like doing it. It's our last resort. We keep that below the inpatient, well below the Joint Commission's inpatient national average. But because we have the ability to do it if we need to as a last resort, that means that we don't ever turn patients away for being, quote, too agitated or too acute. Because our philosophy is we'd rather have those patients rather than have them turned away, because they often end up in an emergency room restrained or jail restrained anyway, if you can't bring them into your crisis facility. Police, yeah. And so police turnaround time, we look at patient satisfaction as well, and our readmissions, which we'll talk about in a minute. We've used so we've got our 2 facilities here, but then our Regional Behavioral Health Authority has used that same framework to create standard reports from the other smaller crisis facilities that are run by other agencies. So we actually then can actually look at the whole system and look at performance as a whole. And so this shows the other ones that are in Southern Arizona. And so then we've also we work really closely with our Regional Behavioral Health Authority, which is Arizona Complete Health. Like I said, they're sort of our benevolent overlords, depending on where we're at in contract negotiations at any given time. But we really work on trying to use our data to help them manage the whole system. So I like this quote. It's from Brene Brown about how stories are data with the soul. And that's really, because every crisis visit is really a story about how someone couldn't get their needs met in the community. And what we want to do is turn those stories into data. If you think about it, everyone who comes into the crisis center, they have a story. I couldn't get to see the doctor at the clinic. There's a problem with the pharmacy. I couldn't get my meds filled. I can't get my case manager on the phone or whatever. And all of those stories are examples of people's needs not getting met in the community. So what we want to do is harness those into some kind of more discrete data so that we can look at where the gaps are in the community. And if you are a managed care organization, or the Regional Behavioral Health Authority that's over all of this, the best data that you have is claims, which are 90 days old. And so it's like looking back in time, 3 months ago at best. So what we worked out is ways to feed data to the REBA on a daily basis. And so then their staff works on analyzing it, and then we meet together on quality projects. So this just kind of shows that. So, we feed data to the Regional Behavioral Health Authority. Their staff does some analysis of it, and then we have monthly or sometimes biweekly, depending on what's going on, joint data QI calls where we look at those trends and look and see what we can do better. So this is sort of an example of why collaborating this way really makes these analyses more powerful. So each one of these lines is a clinic, different clinic in town, and it shows the percentage of that patient's total clinic caseload that ended up in the crisis center in that month. And these clinics all are various sizes. So just knowing the number of patients from each clinic doesn't really mean anything. But the REBA has the denominator, so they know how many patients these clinics are responsible for. So you can see this orange clinic, which actually was one of the smaller clinics, so it wasn't sticking out. If we just look at our own data, once you pair it, you can see that a big proportion of their people, much higher proportion, are ending up in crisis, and so then the REBA can work with them on trying to see what kind of help they need a lot earlier than if they had just waited to look at claims data. And then this is our Familiar Faces project that we did. So we all have our people who like to come to our facilities. Some people call them high utilizers. We decided to call them Familiar Faces to try to be a little more positive. And so we created a definition of familiar face based on past data. Basically, we took the top 20%, and for our data, that ended up being, I think it was 3 visits in the previous quarter. And if they make, so we have a rolling list of who those people are, and then we work with the REBA because they're kind of, the oversight. So they're able to then bring in the different stakeholders that need to be there for these multi-agency staffings, where we talk about that person and what is not working for them in the community. And more and importantly, we know they're going to come back to us. And so what are we going to do differently next time they come back? And so then we flag their charts, and it's just pretty simple. Like, here's an example of one of them where it says, do not discharge until you call this guy's case manager, Jerry, and that's his cell phone number. And that's as simple as it is. So this kind of shows our results. So when we first did this, we had 64 people on the original list. And then a year later, only 7 of those original 64 remains meeting that familiar face criteria. And then there were only 37 total that even met that criteria. So not only did we help that individual cohort of people, but we also kind of decreased the churn altogether. So this is an example, like what we actually did. So this was a lady who would come in, she had kind of limited coping skills. So over the weekend or in the evenings, she'd get kind of lonely, and then she would get all kind of ginned up and anxious and ruminate and become suicidal. And so then she would call the crisis line or 911 or end up at the crisis center. And so on the one hand, you could look at that as, why won't she go to the clinic? We've been trying to get her connected to a peer in the clinic, and she won't go to the clinic. She's always coming to the CRC. On the other hand, you could look at that as a positive. It's not that she can't form good therapeutic relationships. She's got a very good one with us, and she knows our staff by name, and she loves our staff, and she feels safe with us, so she comes to us. So we needed to have her develop that with someone who's not us. So her plan was pretty simple, which was every time she came into the crisis center, we would get the peer down there immediately to meet her, because she never even met the peer because she was never in the clinic. And then she developed a rapport with that person, and then started to use that person as a support. And her partner was in services as well. And so the clinic did some work with them both so they could learn to support each other better. And so this shows the results. So in that first quarter, she had 14 visits. And in the same time period, a year later, just 1. And then overall, we had decrease in our readmissions. We look at 72-hour readmissions for the 23-hour OBS units, because it's similar to what emergency rooms look at. And then our inpatient unit, we look at 30-day, and those decreased as well. And then just to wrap up quickly, so there's time for questions, we also can work together around mobilizing the whole community around some improvements. So this is, we have a lot of people, I mentioned, on assisted outpatient treatment. And if they're not adherent with their treatment or they decompensate, then there's an order to bring them in. It's called a revocation. And so then they get picked up and brought in to see us. And so this is a histogram of how many visits people have in a given time. And you can see that there's some people that were coming in 6 times a month. And so, who are these people and why? So the police department knows, because they're the ones who are actually picking these folks up. And so they did some kind of hot spotting based on location. And so a lot of where all these orange and red is, turns out those are group homes. And so it's like, well, how can the community work together to get those people's needs met a little bit better? So we have this big, huge multi-agency project where this is another quality improvement kind of nerd tool over here. It's called a swim lane chart, where in the important thing isn't to look at all the different steps, but that every lane in there is a different agency that came together to work on a common process. And so what was happening was, you've got a group home, there's a resident there, they get into an argument with another resident over like cigarettes or the phone or something. They get at, then someone calls the police says they're revoked and come pick them up, or the clinic says they're revoked, tells the police to come pick them up. They bring them to us, and we're like, we don't even know who this person is. And then the police are all upset because they realize they kidnapped somebody. And so they're the ones who really came to us to ask if we could help stop this. And so we worked out a thing where now the group home calls a crisis line, or if the crisis line, they're supposed to call not the crisis line, but they call 911 instead, then they can divert that over to the crisis line. And a mobile team goes out and tries to resolve the situation, and then only if they can't, they'll come and see us. And so you can see after we started that, the revocations just started trending down. And just to end, we're very blessed to have a really robust system here, really good system partners, but it didn't happen overnight. It's been a 20-year journey. I've only been here since 2014, so kind of late, but it took a long time to get here. So just don't feel discouraged if you're looking at this and go, well, we can't do all of that. Tucson didn't do all of that all at once either. And so kind of lessons learned is that really what's in this red here, which is try to have a culture of no wrong door, to figure out how to say yes instead of looking for reasons to say no. And just, collaboration and data. And so with that, I will end. Also, I mentioned we're a learning site through the Bureau of Justice Assistance. So if you follow that link, you can actually get some federal funding to come visit us when there's not coronavirus, hopefully. And with that, I'm open for questions.
Thank you so much, Dr. Balfour. The intersystem collaboration is clearly a major strength of your crisis response system, and the mind just reels at the amount of coordination that's happening between your various partners and systems. I'm going to go ahead and start our Q&A period with the questions that have come in. We're compiling those questions between those that came in via chat and the Q&A box. The first question, Dr. Balfour, comes from Carla Jo Whitson. She asks, as part of your intake, are clients asked if they have experienced traumatic brain injuries or concussions?
Yeah, well, it's part of the psychiatrist's psych evaluation.
Great. Next question, how do you approach setting values system-wide?
So we've got a very collaborative group down here, as you noticed. The county plays a very strong role down here, and they've been a real leader, and they partner very closely with the Regional Behavioral Health Authority. And so that's where kind of a lot of that direction comes from, where the county is very clear about how they want people in the least restrictive setting. The Regional Behavioral Health Authority, getting its direction from the state, has very clear directions, especially around keeping people out of jail. And so it's really kind of those points of strong leadership that convened people around the table to discuss these values and kind of make those be a common shared set of values.
Thank you. We also had a question, how are individuals forced to be involuntary at the crisis center? Can you speak to that?
So if there's a couple different routes, I mean, every state's got their own different civil commitment, but if anyone in good faith can fill out what's called an emergency application, and then police have to transport, and they'll transport to us. And so that gives us 24 hours to decide whether to proceed with the civil commitment process, which at that point, if we file that paperwork, then there's a 72-hour period for 2 psychiatrists to do evaluation, and then a hearing and all of that. By that point, the person's usually been admitted to an inpatient hospital. There's also a non-emergent route, so there's time for people to get their due process, where if it's not imminent risk, but what we call persistently and acutely disabled or gravely disabled, someone can fill out paperwork and have that a team goes out to try to find that person and do an evaluation. A psychiatrist signs off on it, not our psychiatrist, someone else. And then it goes to a judge, and then there's an order for the police, which is always the MIST team that does these pickups, to pick them up and bring them to us to start those evaluations. And then if people are on involuntary, if they're on AOT, the police can bring them in involuntarily. But again, most of them are the police are bringing them to us voluntary, even if they meet criteria for involuntary. They're able to engage with them and have them come voluntarily.
And a somewhat related question, and unfortunately this will have to be our last since we're running out of time here. How did you get to a place of no exclusions for acuity, agitation, intoxication, etc.? I hear a lot about patients getting refused by clinics that don't want to serve them or don't believe that they can.
We like those people, and that's really our company is actually owned by two psychiatrists, and we all kind of think the same in that those people are going to do better with us than if they're taken. Because what's the alternative? If you say no to those people, they'll go to the ER, and that's not good, or to jail. So one is like that's just part of our mission, is that we never turn law enforcement away. We've worked, we train our staff very highly. We use behavioral health technicians who we do a combination of the entire organization gets what's called therapeutic options, is a trauma-informed kind of verbal de-escalation kind of training. And then our behavioral health techs get safe clinch. It's safe, CLINCH, clinch. And they actually came to us with that. We're always looking at ways to improve things. And we were using another training that we didn't feel like it met our needs with the level of agitation and acuity that we get. And so they get that. They do drills. We look at videos to learn from, what can we learn every time we have an event. And really it's just and we track, we don't call police to manage our people. We don't have security in our clinical units. And so we basically, because our philosophy is if our techs are the most highly trained people around dealing with de-escalation, why would we default to somebody who's less highly trained to help us? So that's been part of that. And as far as like the not being too intoxicated and all of that, well, our CMO likes to, a co-owner likes to remind us docs that we did go to medical school. And so, yes, we can treat withdrawal, we can treat hypertension, we can treat diabetes. We have partner ER. So like in Tucson, it's the ER that's right next to us. In Phoenix, it's the one down the street. But we have a really good relationship with our medical director and the ER medical director, so that we're always talking about if we sent someone to the ER that they thought we maybe didn't need to send, we talk through those cases. We work on protocols together to help us be able to serve people. Speaking of, this whole coronavirus thing is, a huge, what are psychiatrists and mental health like? What's our role in this whole coronavirus thing? A huge role is to help keep people out of the emergency rooms, because those emergency rooms, their biggest risk is being completely overwhelmed by this surge of sick coronavirus patients. And so we've worked out protocols where we actually, as soon as we get the supplies, which hopefully that will be today or tomorrow, we will actually do the testing for people with just mild symptoms, because there's no reason for them to go to the ER. So that's just, it's kind of that mentality of let's figure out how we can take care of our own. Another thing that comes up too, when people talk about medical comorbidities and things like that, is people are like, well, I don't want to be liable if we take a medically unstable person. What do you do if the police brings you somebody medically unstable? And my answer to that is, well, first of all, the police are better than you would think at knowing who needs to go to the ER and who can come to our facility. But even if they do bring us, it happens every once in a while. I joke with my cop buddy, I prefer you not bringing somebody unconscious, but it happened once or twice, but I'm sure they were awake when they got put in the back of the cop car. But if that happens, what makes more sense? To come out there and see this person and then declare them too medically unstable, and then tell the police officer to put that medically unstable person back in the back of their unmedical cop car, and then have their unmedical trained self drive them off the property to another ER. And if something happens to that patient en route, what do you think has more liability? that versus you accept them and you have kind of just standard, like we're all trained in basic life support and we have protocols to get people immediately transferred to emergency rooms if that's what needs to happen. Which has more liability, the first one or the second
Right,
one?
right,
That's kind of how we look at it.
right. Thank you. Well, I know we're wrapping up here. We're just out of time. Just a reminder to everyone to complete the evaluation by following the link in the chat. And I'd like to quickly remind everybody about the additional training opportunities that are part of the series for crisis response systems. The next installment is with Dr. Ken Minkoff on March 30th. We'll be talking about designing and implementing ideal behavioral health crisis systems, followed by implementing new crisis services, the view from the ground up, with Dr. Michael Flom on April 15th. And you can find out more and register for these resources and training opportunities by visiting us online at www.mhttcnetwork.org /Northwest, and you can also sign up for our newsletter from our homepage. Dr. Balfour, I cannot thank you enough for lending your time and your expertise on this important topic in the midst of this very busy time. And I want to thank everyone for signing in today and for viewing this webinar and taking the time to learn about this important topic.